All right, thank you, Dr. Halke. So yeah, we will get started with our first speaker. I would say welcome back to Omaha, but I guess we'll say welcome back to the event. We're thrilled to have Dr. Kim here with us again. Dr. George Kim is a medical oncologist at George Washington University Cancer Center. He currently serves as Associate Professor of Medicine in the Division of Hematology and Oncology. Dr. Kim received his medical degree from the University of Vermont College of Medicine, followed by internship and residency in internal medicine at Johns Hopkins Hospital. And his areas of expertise include GI oncology and colorectal cancer, pancreas, liver, gastric, and esophagus cancer. So we are thrilled to hear of gastrointestinal cancer updates from ASCO. George, welcome.
Thank you, thank you. I'm having some issues with the controls, but here, let me try this. Okay, here we go. All right, so thank you. It's great to be with you again, as always. Thank you for inviting me, and this is neat. This is great. We do this a lot these days, but this is great. And hopefully we'll get back out there to see some baseball games in the future. Hope everybody is well. I know it's not it's a challenging time, and we're all doing our best. So let's talk about GI cancers. I'm going to try to share my screen here. Okay, here we go. All right, so you guys should be able to see this. You guys can see the screen okay? Perfect. Okay, now everybody can hear me okay, I guess. So, all right. Yep. So we're we're gonna go ahead here. You can see all the stuff that I have on my computer. Okay, so this was what was at ASCO this year. Let me get rid of this control. There you go. Okay, so we did have a plenary presentation in colorectal cancer. We got some more data on the adjuvant 3 versus 6. I think that's some of the final data. We're going to talk about adjuvant rectal. I think we've talked about that before. And then move on and talk about HER2 agents and also the BRAF data. Move on to pancreas cancer, adjuvant and borderline, and then talk about hepatocellular. And if we have time, we'll talk about some esophageal work. I have to tell you, this year's ASCO was unique in that there was a lot of questions that we ask in clinic every day, and a lot of them were answered. So it was actually very practical ASCO. So next slide then is, okay, so let's talk about the plenary session. This was the big news. Pembrolizumab versus chemotherapy for microsatellite unstable MSI high patients. This was the Keynote 177 study. Just to remind everybody, I know you all know this very well, being from the land of Henry Lynch, MSI high, the microsatellite mismatch repair. This is a Lynch syndrome. About 5% of metastatic, 15% of stage 2, 10% of stage 3, and about 5% of the metastatic. And then there's also association with the BRAF mutation. There is a high mutational tumor burden, and that's shown here. With the MSI tumors, it's thought that this creates more neoantigens that the immune system, the T cells then target, and that's why these patients actually may do better, and that's why drugs like pembrolizumab are of benefit. This was observed early on by colleagues up at Hopkins. They showed here in the mismatch deficient patients, there was high response rates, where in the mismatch proficient patients, there was no response. So very important observations. They went on to do this both in Pembro and in Nivo, and again, responses were clearly seen, okay? So the background again, 5% of tumors, mismatch repair, early studies showed activity, so why not do a trial comparing it to standard chemotherapy? So this is the Keynote trial. Over here, you can see that patients were treatment naive. They had to have measurable disease, randomized to pembrolizumab every 3 weeks, versus the investigator choice. And this was your standard chemotherapy, either FOLFOX-Bev, FOLFIRI-Bev, FOLFOX-cetuximab, FOLFIRI-cetuximab. And then patients went on to be observed to unacceptable toxicity, disease progression, or withdrawal. Dual outcomes, as many of these trials have, both PFS and overall response. Response rate also was an important endpoint. I don't know how well this projects, but down here, I'm just going to tell you that overall, the two groups were well balanced, okay? There were more right-sided tumors than left, as you would expect in this group of MSI tumors. I'm also going to highlight down here the BRAF mutations and the KRAS mutations, and I'll explain why in a little bit. Okay. So this was one of the endpoints, progression-free survival. Very clearly, the pembrolizumab arm separates from the chemo arm and is superior. Here at the 2-year mark, 48 versus 19%. So important. And then here is the PFS, 16.5, almost a doubling versus 8.2. I will highlight here, and this is right around 6 months when the curves cross, okay, at which time it appears that the chemotherapy is better than the checkpoint inhibitor. And so we have to be very careful in how we treat our patients and how we use this, because some of the patients will have undergone treatment, and it's not till over here that you start to see the separation and the more favorable benefit from the pembrolizumab. So very important to consider, all right? But I think down here, it's very obvious that patients would like to be in this area where there's a very large separation with the pembrolizumab. And I'm going to show you in a minute at less cost of side effects. Now, this is showing the what favors pembro versus what favors the chemo. And obviously, the majority of them favor the pembro. But there is this group here, the KRAS mutants, where it does cross and the chemotherapy appears to benefit more. So we do have to pay attention to that when considering the subsets of patients. That's shown here that the BRAF patients actually do well, and then the KRAS here. And there is some data in other sets, other trials that suggest we do have to pay a little more attention to the KRAS mutation status in using checkpoint inhibitors. All right, so tumor response, 43% with the pembrolizumab versus chemotherapy, 33%. I'm going to argue that that's a low number for chemotherapy, that this number should be up in the 40 to 50% range with most tumors. And I think it's a reflection of MSI high cancers, not necessarily benefiting, or there's some concern about resistance. Remember the days of Dan Sargent in the stage 2, stage 3 patients, where there was some concern that there might be resistance to 5-FU. And so this is one of the comments about the trial, that the chemotherapy in these folks, or just in these patients, chemotherapy really may not benefit, and that's why the pembro is actually better suited for these patients. And so here we do see the partial response, the stable disease, and the time to response, again, about 2 months, going back to those curves. There is this here progression disease. More patients in the pembro arm progressed as opposed to the chemotherapy. So again, you have to pay attention to that 6-month crossover. This slide just shows what I said a minute ago, that the chemotherapy, this is from 80405, the large intergroup trial, the chemotherapy in these patients really may not be beneficial, and as compared to the MS proficients. And so that's why using pembro is now considered a standard. This is just showing the waterfall, showing the response rates. And just remember that there is more data coming forward using Nivo and also IPI. This will come forward as well. So a little more work to do, but we clearly have a new treatment. And you also have to look at this in the context of toxicities. These are the grade 3 toxicities associated with Pembro versus the grade 3 toxicities associated with chemotherapy. Obviously, much more neutropenia, myelosuppression, and then down here, the neuropathy. So really not a lot of toxicities with the Pembro versus the standard chemotherapy anticipated side effects. In terms of immune-related toxicities, as you would expect, some colitis, hepatitis, but really fairly well tolerated and well managed. All right, so the crossover, will we ever see survival benefit? There was about a 36% crossover from the chemotherapy arm to the Pembro, and then obviously other immunotherapies are available. So we probably won't see the overall survival benefit, but we'll wait for that data later. So how do we summarize the data from the plenary presentation? Very clearly, Pembro does provide a clinically meaningful and statistically significant improvement in PFS. It's a doubling here, hazard ratio of 0.6, statistically significant. And again, I showed you the 2-year PFS benefit. I also showed you the early progressors that occur within the first 6 months and how the chemotherapy curve is above the Pembro. We have to look at those patients very clearly. Some more work has to be done in identifying those early progressors. Response rates we've talked about, 43 versus 33, and the duration upwards of 10 months in the chemo arm and hasn't been reached in the Pembro arm. The toxicity profile very clearly favors the Pembro group, 22 versus 66, and this is considered a new standard for patients with microsatellite metastatic colorectal cancer. So very important, and certainly has changed the way that we treat these patients. There are some questions that are raised, though, as we've talked about. This 29 versus 12. So patients in the trial did have resistance to the PD-1 therapy. So we have to do work with that. And then what's the best approach, especially in patients that are symptomatic? I've treated patients that have a lot of pain in their liver. Do we want to give them chemo first? Do we want to give them a chemo combination? So we still have a little bit more work to do. We talked about the overall survival. Probably will not see that. This is a little controversial, but what the point here is that this was a colorectal trial, and we obviously see MSI high in other cancers, especially duodenal, pancreas. And the question is, in other GI cancers, whether we should be doing this as well, whether we should forgo chemotherapy and just use immunotherapy. Some people have begun to advocate for that. I think it's a little early, but it's certainly intriguing, and we certainly have to await the other trials that will look at this question of chemotherapy versus checkpoint inhibitor in the non-colorectal MSI high patients. And then the final bullet is that we need to use these treatments in the earlier stages. There are adjuvant and neoadjuvant trials ongoing, and so those also will be very interesting. So that was the big presentation from ASCO in terms of the plenary. Let's move on. We got some more results from the IDEA trial. This is the 3 versus 6 adjuvant oxali. This was, just to remind everybody, 13,000 patients across the globe, and also the US 80702. This was the paper that was published showing a hazard ratio of 1, that 3 is not inferior to 6. These are the statistics. This was the primary objective, showing non-inferiority. So a double negative here, a 3 versus 6. This is the updated data. Just to remind everybody, this is the upper confidence interval, 1.11. So this is what was considered not inferior, as shown here. If you're, we're comparing 3 versus 6 months. So if you're on this side of the hazard ratio of 1, then 3 months is actually superior. If you're beyond the 1.11, then it is not. And that 6 months is actually better. If you're in the middle, it's not proven. And if you're here, then it's not inferior. I know it's a double negative here. It's kind of hard to understand, but that's where you are. So at the end of the day, the overall survival in the populations is no different, okay? So this is our Italian colleague commenting, the debate is over, 3 months wins, okay? So 3 months is better and that the toxicity is lower. So let's go through what he's trying to comment on. Here, the hazard ratio at 5 years, again, not showing much of a difference. But when I sit with patients, and I'm sure when you all sit with patients, they ask, what are the numbers, okay? And what I'm showing here is the Xeloda Capox versus the Folfox. Remember, this was not a comparison between the two regimens. It was a comparison between 3 and 6, and investigators were allowed to use the two different regimens, the Capox and the Folfox. But what has come out of this is that if you look here, I don't know how hard this is to see, but at 3 months, the survival is 82, and at 6 months of Folfox, the survival is 83. So I know we're splitting hairs here, but patients will come into my office and say, what gives me the best chance of survival? And unfortunately, this number is higher than this number. And sometimes patients will say, well, I want Folfox for 6 months. But in terms of 1 or 2% difference, it really is not that different. So in terms of disease-free survival, which was the primary endpoint, again, 70 versus 71.7, a 1.7% difference. Does that really mean that much? Looking at other populations, this is a garden variety T3N1 or a T1N1 versus the higher risk patients T4 and N2. And here there is a separation of about 1.7%. Again, looking at the Folfox, looking at the 6 months versus the 3 months. So in this group, this higher risk stage 2, one would consider giving 6 months of treatment. And then this is shown here. I don't know if you guys can see the numbers. In the low risk groups, the 3 month Capox versus the 3 months Folfox, the numbers are here. And then in the higher risk, the numbers do drop down to 75%. So there is, a higher risk of recurrence. We've known this in the high risk patients, and one might argue to give them Folfox for 6 months, but everybody else, it's very reasonable to give 3 months. So the summary of the IDEA trial, 12,000 patients, toxicity is lower, and I'll show you that in a minute. The disease-free survival at 3 years, overall survival at 5 years, and disease-free survival show minimal differences except for the high-risk patients. And so I think more and more we're seeing patients being treated for 3 months with Xeloda and oxaliplatin. Now, this is also the major question that patients ask me. If I get 6 months of Folfox, my grade 3 neuropathy rate is 16%. If I get 3 months of Xelox or Capox, I get 3%. And then even a grade 2 toxicity, these numbers are meaningful. So when patients come into the office, this is something that we discuss. It's very important. The neuropathy is significantly reduced with the 3 months of Capox. Also, in extrapolating to the stage 2 patients, we can also consider the 3 months of Xelox, especially in those high-risk patients, and I think we're doing that more and more. Okay, so that's the data from IDEA. Practical implications, 60% are low risk. It's reasonable to give them Capox, Xelox. The high-risk patients, the T4N2s, consider 6 months of Folfox. And then I just want to remember Dan Sargent, who obviously was a colleague back at Mayo, who was the mastermind behind this trial, but who died several years ago, unfortunately. All right, so let's move from idea to move on to data from 80702, the American component, stage 3 colon cancer patients using Celebrex, celecoxib. So for many, many years, we've been looking at aspirin and COX-2 inhibitors. We know that they're helpful in reducing cancer risk in familial colorectal syndromes. So what is the real benefit? This has been a challenge to see a real benefit. This is the trial design using Celebrex for 6 months. And again, this was the 6 versus 3 study. So again, this is 6 months, this is 3 months. And this is the result. There really is no difference here, 76 versus 34.5. The p-value doesn't reach statistical significance. Ironically, when you look at this difference and you go back to the IDEA trial, we were talking about 1.7-month differences as being meaningful. Here, we have a little bit of a larger delta, but again, this is not statistically significant. In the overall survival, also 84 versus roughly 82 here, about a 2% benefit. But again, this is considered not significant. And then hypertension was seen more when Celebrex was given during the chemotherapy, and an increase in creatinine was seen more. So the bottom line is you can't use these drugs in the adjuvant setting. And so we just have to wait. All right, so moving on, this is an important trial because we always ask, in the patients with stage 4 disease that undergo resection, should we give them chemotherapy? In my practice, I do give them chemotherapy. I typically give them chemo for up to 6 cycles or 8 cycles, 3 to 4 months, typically FOLFOX, and then I follow up with the chemotherapy afterwards. So this is the Japanese study looking at whether FOLFOX should be given after hepatectomy. And so this is based on some of the EORTC data, looking at survivals. There was a progression-free survival benefit of about 10 months. Overall survival, unfortunately, did not increase. And I think that's what you're going to see in these trials, and I'll try to explain that. But this was a study design, resected colorectal liver mets. Patients were observed versus receiving FOLFOX in the post-op setting for 12 cycles or 6 months. The initial trial was a phase 2 looking at compliance, and then they went on and did the phase 3 looking at disease-free survival, overall survival. This is the consort diagram, pretty well done. The point here is that obviously a good number of patients drop off in terms of being able to tolerate and complete all the chemotherapy. This is the patient demographics. Synchronous tumors, about 84%. And then the size of the tumors. This is the primary endpoint. The chemotherapy here is showing a benefit, 49, almost 50% versus roughly 40%. And this is the confidence interval and a statistically significant one-sided p-value. So there is a benefit, but when you look at the overall survival, I'm sorry, here, looking at disease-free survival, as you would expect, synchronous tumors do better. Tumors that are smaller do better. Tumors that are left-sided do better. And tumors, the patients with fewer tumors do better. So as you would expect, these groups of patients do better. In terms of overall survival, though, we don't see it. And if anything, surgery appears to come out on top. This does make sense when you consider where the patients recurred. The patients that had surgery recurred in the liver only, and these patients went on to resection. Some of the patients had recurrence both in the liver and the lungs. And then it did change the patients that got chemotherapy, more tumors, obviously, having undergone liver resection, their tumors ended up in the lung or in the extrahepatic or extrapulmonary regions. This is a little worrisome if they end up having peritoneal disease because this is so difficult to treat, but it helps you understand where the cancers will recur. And also second-line treatments, as you expect. Patients that had surgery alone went on to receive, more went on to receive oxaliplatin than irinotecan. And again, the types of resections that were performed, patients that had surgery, there were more R0, R1 resections than patients that had chemotherapy alone. So how does one use this data? I still think it's meaningful to give chemotherapy around the time of liver resection. I think it allows the patient in the improvement in disease-free survival. It allows them to have time potentially away from treatment. It does buy time during the years or so after undergoing the therapy. But in terms of long-term survival, I think in the manner in which we recycle drugs, recycle therapies, have our interventionalists get involved, have opportunities for re-resection. I think there are other treatments that ultimately, that's why we don't see these improvements in overall survival. But I think in the short term or in the term around the time around the resection, it is meaningful. So a very important study, and I think very helpful. All right, so let's move on. Now let's talk about treating rectal cancer. And this is a trial from the French looking at total neoadjuvant therapy. And I think we're doing this more and more. This is a phase 3 study. Just a reminder or some history. We've done pre-op chemotherapy radiation since 2000. But unfortunately, patients do recur upwards of 30%. It is increasingly feasible, but compliance or post-op chemotherapy is not well tolerated. Upwards of 50% of patients don't receive post-op chemotherapy. And for all these reasons, that's why we want to deliver treatment upfront as best we can, or as most of the chemotherapy upfront. And then this regimen, FOLFOXIRI or FOLFIRINOX, does have high response rates. So what did the French do? They took patients, they randomized them, they underwent MRI staging, and they randomized them to upfront chemotherapy, followed by resection, and then the conventional 6 months or 12 cycles of oxaliplatin-based treatment. Some patients got CAPE. Alternatively, the experimental arm, they gave chemotherapy for 3 months or 6 cycles, went on to chemoradiation, then resection, and then gave additional chemotherapy. In the US, there are trials where we're giving all 12 cycles of chemotherapy and then going on to chemoradiation surgery. But this is the French approach. This is more of a perioperative chemotherapy approach. The primary endpoint here was disease-free survival, 230 patients in each group. And then I'm just going to highlight again the adjuvant post-op chemotherapy, about 70% in the TNT and about roughly 69%. So not a big difference here in terms of one of the objectives of getting more chemotherapy in. In terms of responses, though, what you do see is a higher rate of what they call complete or near complete responses. So the response rates do go up when you give total neoadjuvant treatment. In terms of the compliance we talked about in the post-op setting, it's roughly the same, so you didn't really change that. And then in terms of disease-free survival, shown right here in the red, the TNT group does better than the conventional group. So this is very provocative, but should we be giving more chemotherapy, and not just chemotherapy radiation, before we take patients to surgery? Prognostic factors, if we do a multivariate analysis, you see very clearly the TNT patients do better. Metastasis-free, we do see an improvement here of about 7%, but we also have to look at overall survival, and that data will come forward later, okay? All right, so very provocative. Should we give more chemotherapy before we do chemotherapy, radiation, surgery in our rectal patients? This is another interesting study that was done, again, in rectal cancer, Dutch or European investigators, and this looks at short course radiotherapy. This is what we're talking about. This is conventional treatment, 5.5 weeks, waiting and then doing surgery and then giving additional chemotherapy. But what if we can give radiation over 5 fractions, 5 by 5 down here, so 5 fractions of 5 gray over 5 days, give a rest, then give chemotherapy, and then go on to surgery. So again, a kind of neoadjuvant approach, but using a short course of radiation. So if we use that approach, I'll just tell you also, the patients did have high risks. N2 disease, I'm going to argue, is going to be more important to give more chemotherapy, obviously, with a higher number of lymph nodes. There were a lot of these patients, roughly 65%. And then in terms of efficacy, in terms of residual tumor, did we receive a pathologic response? It was higher, double in the short course group. And then the resections also were the same, but there were a higher number of pathologic complete responses seen in the experimental group. Disease-related failure, experimental arm did better. Distant metastasis, and then finally, local regional failure, which is really what we're looking at in terms of the short course. Does it compromise local control? And this is about a 2.7% difference. So I'm going to argue that it didn't, or it was very similar. But again, we're not necessarily affecting distant metastases, which is ultimately the reason why these patients succumb. And then shown here, overall survival with the two approaches is about the same. So take-home message is that you do improve disease survival. Perhaps you improve distant metastases. Overall survival is not affected. It is not compromised. So if you do have a patient that you want to give short course radiation, I think it's very reasonable to do so. All right, let's move on. So we've talked about the MSI patients. Now we have another subgroup of patients, the BRAF mutated. This is the Beacon trial, the updated survival. This has already been published. This is the work from Kopetz from MD Anderson. Just to remind everybody, BRAF mutant patients, roughly 10 to 15%. We tried BRAF inhibitors, but it became very clear that there were resistance pathways mediated by the EGFR pathway. So by blocking with cetuximab, one can then get responses. And then we also understood the RAF-MEK pathway, that if you inhibited MEK, you could potentially increase activity. So this is the Beacon trial looking at encorafenib and binimetinib in BRAF mutated patients. So again, this is the this is the control arm looking at FOLFIRI cetuximab or irinotecan cetuximab versus the cetuximab encorafenib. So there's no chemotherapy in this arm. Same thing here, the bini and the encorafenib, cetuximab, no chemotherapy. And again, primary endpoint, overall survival, as well as response. In terms of patient demographics, well balanced, just noting here about 10% have MSI high. Updated survival showing the doublet versus chemotherapy, 9.3 versus 6. And then the triplet here, 9.3 versus 6 also. So the point here is that you don't really see a lot of added benefit from the MEK inhibitor. And then here, the curves together, clearly better than the chemotherapy arm. So in this group of patients, encorafenib cetuximab is the standard. Here are the response rates, maybe a little bit higher with the triplet, but certainly better. And then progression-free survival also improved, not much of a difference. There is some toxicity, but this is fairly well managed, especially in comparison to standard chemotherapy. Okay. All right, so this is the standard. I'm going to jump ahead really quickly. I know we're running out of time here. This is a trastuzumab deruxtecan. This is an interesting molecule that's now available. This is kind of your TDM1 for colon cancer. Uses the HER2 antibody, a linker, and then this agent, which is a topo1 inhibitor. This was the trial looking at IHC3+ or FISH positive HER2 patients. This is the dose. The point here is that there were about 30% of patients that had prior trastuzumab or pertuzumab lapatinib therapy. So that's interesting, and I'll show you in a minute. Response rate's 45%, so very meaningful with the drug alone, no chemotherapy. The waterfall plot, these little yellow pyramids here, or arrows, are the patients that had prior HER2 therapy, and clearly they still respond. This is the forest plot, again, showing prior HER2 therapy. They did appear to have a response rate at the median of roughly 43 to 45%. And then finally, the overall survival and progression-free survival, very encouraging. Toxicities, it does cause neutropenia, surprisingly, at the grade 3 level. And then finally, the reason you can't just give this drug by itself is that it does have associated with it interstitial lung disease. So you have to be careful monitoring the patients for interstitial lung disease, which is unique to the agent. And what's missing from here is diarrhea. There's a little bit here, but not at the grade 3 level, but you do have to look for interstitial lung disease. Okay, so I'm going to skip all this for the sake of time. I'm going to go to pancreas cancer. I'm going to finish up here in a few minutes. Pancreas cancer, we saw were some adjuvant trials. This is the present scheme of trials or treatments for pancreas cancer. Certainly FOLFIRINOX is king here, showing median survival of almost 5 years, 54 months. We do have gemcitabine, capecitabine, showing a survival of 28 months. The Japanese use S1 in a neoadjuvant fashion, showing survival of 36. This is Abraxane, 40 months, and then the PREOPAC study looking again at neoadjuvant. So these are the standards. Most patients being treated with modified FOLFIRINOX. SWOG did this important study looking at FOLFIRINOX versus Abraxane in resectable, not borderline, but resectable patients. This was the criteria. You could not have any involvement of the major vessels, had to have a patent SMV, and obviously no metastases. These were the treatments. Patients received FOLFIRINOX for 6 doses, went on a restaging, and then surgery if there was no progression, followed by additional treatment. And then here with the Abraxane, the same scenario. These are the doses, no bolus 5FU. They were looking for about a 20% benefit from a historical control of 40 to 60. This was the timeline. This is important because it highlights there's a lot of enthusiasm about neoadjuvant trials. Patients were accrued very quickly. Unfortunately, about a third were not eligible because it was later deemed that they had more advanced disease. So they did have to redo the statistics, and they ended up with 100 patients, 50 in the FOLFIRINOX and roughly 50 in the Abraxane. The point of this is just to show you that a good number of patients drop off in terms of receiving postoperative therapy. Only about 50% of patients were able to tolerate postoperative therapy. And also, the patients that underwent resection, about 25 to 30% of patients drop off and don't get to go to surgery. So that's an important lesson. Some surgeons will say that we're identifying patients that have more aggressive disease and that the Whipple procedure is not going to help them anyway, and that the survivals will optimize the benefit to the patients. That's still controversial. Here's the overall survival, roughly 20 months, okay? And they did not reach the target at roughly 60%. Survival was in the 40% range. And here, Abraxane appears to be 47 versus 43% 2-year survival. In terms of toxicity, as you might imagine, again, the bolus is not given in the FOLFIRINOX. The Abraxane had the 38% grade 3 neutropenia, but otherwise, the neuropathy was seen more in the FOLFIRINOX group, but otherwise, arguably well tolerated. This goes back to what I said a second ago in terms of the resections. A good number of patients drop off. We started with 102, now we're down to 73. So again, a third or a quarter of the patients drop off. We did see very good resections, upwards of 85% in both groups. So the conclusion is survivals are about the same. There may be some more it may lean a little more to the Gemabraxane, but there is certainly enthusiasm about these trials, and we need to have them continue. I'm going to skip this. I'm going to jump to, just in the last few minutes, hepatocellular. This agent is being brought forth by our colleagues in China. It's a deuterated derivative of sorafenib. It appears to stay in the body longer or is stable. This was a Chinese study looking at this agent. As many trials in Asia, most of the patients were hepatitis B. Why is that important? I know we don't see a lot of hepatitis B here in the United States, but there's some suggestion that hepatitis B patients don't do well with sorafenib, and this agent may then replace that group. These are the curves, and they argue that there is a survival benefit of about 2 months, and there's less toxicity by about 10% at the grade 3 level. So we'll have to see what happens. So what do we have now? We have atezo-bev in the front line. We have lenvatinib. I still believe we have sorafenib. I'm a little concerned that this drug will ever make it to the US. Again, it was done all in China. These are the other treatments that we have, and we're going to see more and more of these checkpoint anti-VEGF therapies. I think there's some very interesting data with lenvatinib and pembro, so we'll have to see all that data as it comes out. So for the sake of time, I'm going to stop there because I know that we want to save some time for questions. So what did we learn at ASCO 2020? I think we need to really focus on those subsets, you know, in the pie diagram, the MSI high patients, the HER2 patients, the BRAF patients, because I think we're seeing more and more biologics or smart targeted therapies that will supplant cytotoxic chemotherapy. And very clearly, we saw that in the pembro trial in the MSI high patients, where they can be treated and not encounter the toxicities associated with chemotherapy and have significant, meaningful benefits. In terms of the adjuvant, I think 3 months is king. I think Xelox or Capox, 3 months is better in terms of outcome is probably equivalent by a difference of 1 to 1.5%, but the toxicity is upwards of 3 to 5-fold less. So that's why most patients in my practice now are receiving the 3 months of Xelox. Even my stage 2 high-risk patients, that makes it a little easier. You don't have to give them the pump, the portacath, all the 6 months of treatment. You can get away with the 3 months. I will caution you, though, the N2 T4 lesions still need FOLFOX for 6 months. We talked about total neoadjuvant rectal treatment. We talked about short course rectal treatment. I think we still need to focus on improving overall survival, but at least we're maintaining local control, which is very important, allowing patients to maintain their function and not be committed to a lifelong ostomy. In terms of pancreatic cancer, nab-paclitaxel and gemcitabine did surprisingly well in the neoadjuvant trial done by SWOG. And then at hepatocellular, we're seeing more and more options. I think that's important, especially when we look at some of these checkpoint inhibitor combinations, anti-VEGF combinations. The horizon for hepatocellular, after a very long delay in terms of advances, we are seeing improvements that are coming forward. So with that, I'm going to stop, and I'm going to thank you all again for allowing me to come out to your ASCO review. And hopefully next year we'll be back at the ballpark watching some College World Series. Thank you.
Thank you, Dr. Kim. We did have a couple of questions come into the chat box. So the first one is, hi, do you think that initial PD in pembro arm could be due to pseudo progression, as the authors said they did not use iResist?
So that where the curves come down initially, I guess the question is that pseudoprogression. You know, I think in speaking with the investigators in the trial, they were aware of pseudoprogression. They were allowed, if the patient was clinically benefiting, to stay on study. So I do think there is this entity of super progressors. And I think, unfortunately, that's an area where we need to focus. And that gets back to, should patients receive, remember how the curves change early on, cross. should those patients receive induction chemotherapy and then go on to checkpoint? And I think that's probably what we'll need to consider. But yeah, pseudoprogression could explain some of that crossover, but I think a lot of it has to do with there are those patients out there that just aren't going to benefit early on.
Okay. The next question is pancreatic CA adjuvant FFX data much better than GEM/AB. So why peri-op both equal?
Yeah, that's a great question. And, I'm on the intergroup pancreas task force, and I asked that question. I said, don't we already know the winner? But I think it's similar to the colorectal 3 versus 6. We're looking at toxicities, not only efficacy. And adjuvant postoperative is different than perioperative or preoperative. So it was a small trial that SWOG did. There were a lot of challenges, but it did suggest that NAB, paclitaxel gem, can be useful in this setting. And I think we need to do further studies. And so I sat in the room and I said, don't we know the answer isn't FOLFIRINOX best? And I think the group agreed, but also still want to look at Abraxane gem in the preoperative setting, not only based on efficacy, but also based on side effects. So great question.
Next question is, thank you for the discussion. You made a comment that patient with synchronous oligometastatic colorectal cancer to the liver undergoing resection was better prognosis than metachronous. May I have you clarify that slide?
Yeah. So synchronous is patients that show up with the primary and the metastasis, and then metachronous are patients that undergo potentially resection of the primary. They may undergo chemotherapy, and then they have tumors show up usually within the first 2 years. So there are a couple of issues there. One is that the patients that receive chemotherapy, it's typically for the primary resection, it's typically oxaliplatin. Then you're going to give them oxaliplatin when their liver metastases come later on. They potentially are resistant. So yes, they could have worse prognosis or worse outcome. Certainly if they come back within the first 6 months or 12 months. So that's what that's referring to. A patient that has a solitary lesion 3 or 4 years later may have a more indolent stage 4 disease, and those patients actually may do better. But according to the Japanese trial, the synchronous patients did better, probably because they weren't oxaliplatin or chemotherapy resistant.
Next question is, what is your standard now for rectal cancer LR adjuvant, neoadjuvant treatment, TNT or the standard SCRT, seeing as PCR is so much higher than and DFS is better?
Yeah, so where do we use short course radiation? We use a lot of short course radiation or hyperfractionated radiation in pancreas cancer, and we might even do it for patients with metastatic disease who have refractory pain. But in rectal disease, you really, it depends on the patient and what they want to endure. Do they want to take the 5.5 weeks of radiation, or do they want to have a short fraction of 5 days? And also whether they want to receive all the chemotherapy up front. And one has to make the argument that patients don't take a lot of chemotherapy in the postoperative setting. They're not able to tolerate it, having undergone the radiation, having undergone the resection. Many patients are not able to tolerate it. So more and more, I think in our clinic, we didn't used to give FOLFOX in the pre-operative setting. So we are giving some FOLFOX. We're not giving all 12 cycles. We're giving perhaps 6 cycles. But as you know, patients want that cancer out of them, understandably. And so not a lot of patients will sign on to that. But we do offer FOLFOX up front. And the surgeons will tell us also, if there's concern about preserving sphincter function, if there's the potential that they're going to have a positive margin, then yes, we will give them chemotherapy and we'll continue to re-image them before we take them onto chemotherapy, radiation, and surgery. The short course radiation therapy is also beneficial in our metastatic patients So they have metastatic rectal cancer. We give them chemotherapy. We do a liver resection, but we still want to have local control. We want to preserve sphincter function. So then we'll give them the short course. At the very end, we'll also be able to preserve bone marrow function should we need to treat the patient if they recur with metastatic disease later. So that's how I incorporate these into my practice. I think there's a large American CLGB trial that look at total neoadjuvant treatment. And I think we will slowly move the trend, but for right now, it depends on the features of the cancer as to whether we employ these approaches.
And we have one last question. What is your general strategy for the late line therapy in MCRC 3L and beyond? If no clinical trial is available, and how does it differ by patient subsets, in parentheses molecular? Do you recommend SOC or EGFR rechallenge? Sorry, I kept sending this privately. Somehow Zoom changed settings.
So, that's a very complex question. I think in the context of this year's ASCO, you really again have to be looking, and I don't think a lot of people are looking at HER2. Certainly the BRAF, the MSI. I think those groups we continue to have to look. The NTRK, we continue to have to look for in our tumors. In terms of what I do beyond chemotherapy, typically I think in the U.S. we use a lot of anti-VEGF therapy in first and second line. Many times patients will also receive EGFR inhibitor, more so in the front line now, in the RAS wild types, especially left-sided. Will I rechallenge if in the second line? So let's take the scenario of a patient left-sided, RAS wild type, gets chemotherapy plus cetuximab or panitumumab in the front line. They go on to chemotherapy and anti-VEGF therapy in the second line. Will I recycle my anti-EGFR therapy in the third line? You can. And there's good data way back to the BOND-2 trials that showed that you can still get activity. In single agent EGFR inhibitor, you have to remember, it does create a 30% response rate. I think that's overlooked when we look at the other refractory treatments. We do get a good response rate. In that setting, I would also consider regorafenib. You don't get a good response rate, but you can cause disease-free survival. We talked about this last ASCO, especially if you dial up the dose using 80, moving to 120 and then 160. Most patients do stay at the 120 dose, but you certainly can maintain disease-free survival for a period of time that is meaningful in the refractory setting. Bottom line, though, you really have to be checking for these subsets and getting patients to these treatments. So very, very interesting times. And we are, again, taking slices out of the metastatic colorectal population and hopefully benefiting subsets, which is something we talked about years ago at this very meeting.
All right. Well, thank you so much again, Dr. Kim.
Thank you again. And everybody be well out there. I hope to see you guys in the near future.
Thank
George.
you.
Thanks.